Thanks very much for a terrific symposium and for this invitation. I'll be talking about the clinical decision-making in Kawasaki disease, and I'll highlight a couple of other cases of different coronary arteriopathies as well. These are my disclosures. So we'll talk about the coronary sequelae. We'll talk about some contemporary catheter-based interventions, and I'll give some case examples, and then discuss surgical versus catheter-based approaches, and leave some perhaps more questions than answers in some of these cases. In this paper by Nakano, it was shown that the larger the aneurysms early in the disease course, the greater the likelihood of developing eventual coronary artery stenosis or occlusion. That became very clear very early on in the 80s even. An additional paper showed that basically with increasing time interval between the disease and the time that you do the angiogram comes the decreasing likelihood of aneurysms still being present, but the increasing likelihood that these will have converted to stenoses or occlusions. Again, this is all very well established and well known. In analysis of myocardial infarction cases, it was shown that myocardial infarction can present asymptomatically and be discovered late, or can present in a fatal situation. It most commonly occurs in the first year after the disease, but up to a quarter of patients can still present with MI beyond the first year after disease initiation. And most commonly, a fatal MI was associated with two-vessel disease, either left main or right plus LAD was most typical. So Teiji Akagi came up with these recommendations where basically he proposed the following: that percutaneous transcatheter angioplasty is effective in many situations, particularly in patients without severe calcification, and usually within a relatively short time course until the angioplasty, within 6 years of disease onset. Because the longer you wait, the more likely there is calcification and the more likely that simple angioplasty won't be effective. He suggested that angioplasty could become a first-line procedure in younger children because catheters can deliver these small balloons in young children quite effectively. Stent implantation is generally deemed to be preferable to angioplasty alone because it prevents the incidence of a new aneurysm formation, which is one of the dreaded complications of an angioplasty in Kawasaki, is to create an aneurysm because of an intimal and medial tear. However, in patients older than adolescents, stent implantation should be considered instead of angioplasty alone, but for younger children, really, that was thought to not be as practical, and therefore, under 13 years of age, they recommended that stents not be considered first-line therapy just because of the more difficult course of placement of stents in small children. So let me give you an example of a case here that we treated. This boy developed Kawasaki disease at 4 months of age. So again, right away, big risk factor. He's developing this in infancy. Received IVIG within 8 days, so somewhat delayed initiation of therapy. And then had another hit in terms of a risk factor, developed a recurrence of Kawasaki disease 1 month later with all the classic symptoms. So again, second course, typically worse disease. On CT angiogram, he was already seen to have giant aneurysms of the right coronary artery, the left main, the LAD, and the circ, and had multiple systemic aneurysms, including axillary, lateral, thoracic, renal, the infrarenal aorta, the common iliac artery, again, just highlighting just the terrible inflammatory state he was in. He was given multiple additional rounds of IVIG. Eventually, the disease stabilized. He was started on low molecular weight heparin due to the presence of giant aneurysms. At 18 months of age, he was suspected to have an LAD occlusion on CT and was thought to have some septal dyskinesis on echo and was transferred to us for management. So I took him to the cath lab, and what do you see here? He already has occluded his LAD. You can see here anteriorly the LAD is missing. This is the diagonal branch. And this is the right coronary with multiple aneurysms throughout its course. And you can see at the typical scenario is stenosis at either the entry or the exit point of the aneurysm. And you see a tight lesion just proximal to the distal most aneurysm here already developing. And again, he's very young. He's 18 months of age. So these are the maximal dimensions: 9 millimeter in the left main aneurysm, and 7 millimeters on the right. At 5 years of age, the CT angio showed calcification and a new high-grade stenosis of the left main, just proximal to the giant aneurysm that he had. The MRI showed stress and rest perfusion defects in the anterior and posterior septum, and so he returned to the cath lab. And what do you see here? within a very short time, severe progression to a distal left main stenosis leading into the circ. And this is what it looked like in a different angulation. Very, very tight. These are some of the dimensions we see here measuring. This is almost difficult to measure in the cath lab. They're so small, that's thread-like. And this is what it looked like on the right. And now you can see that the disease has progressed even in the distal right coronary aneurysm. So at 5 years of age, he underwent a Lima to LAD graft and had normal ejection fraction, fortunately. He was taken to the cath lab 1 year later for surveillance angiography. And this is his graft. Our surgeons did a terrific job and beautifully patent graft. You can see typical findings of also a fistula into the pulmonary artery, which is very common through transpleural collaterals. And this is now the right coronary. And look at that distal aneurysm. Just at the entry site into the most distal aneurysm, it's almost an occlusion. And you can see now that there's also evolution of the proximal right disease with diffuse narrowing occurring between the segment of aneurysms there. This is after angioplasty with a 1.5 and 2 millimeter balloon in the distal RCA. And you can see that there is some substantial improvement there. It's not perfect, but it's better. And this is now tackling the distal left main. Now, as you can see here, this is now more than just left main disease. It's left main disease and proximal circ disease. So his last remaining vessel has very severe stenosis. And so what we decided to do is to wire the circ and also wire the ramus branch independently. I did this case with my colleague Jose Diaz, who deserves a lot of credit, one of the adult cardiologists that we've been working with. And this is after angioplasty with a 1.5, 2, and then 3 millimeter balloons, and the ramus was angioplastied as well. And this is what it looks like after placement of a stent. So this is a left main stent in a 6-year-old boy, a 4 millimeter by 16 millimeter Promus Premier stent that spans both the distal left main and the proximal circ. It does jail the ramus, but the vessel is widely patent after having had an angioplasty. And then we did a surveillance, quick look at that right. We started with this angioplasty and went back at the end, make sure it was still looking okay, and we left it this way. After the left main and circ stenting and the angioplasty of the distal right, he was maintained on aspirin, clopidogrel, and warfarin. And at 6.5 years of age, he underwent another surveillance angiogram. And what do you see here? Complete occlusion of the area of angioplasty. So we brought him back within 6 months because we worry about these patients and we know this can evolve. We went ahead and planned for placement of a stent. And this is after the angioplasty that we performed and showing some recoil. There's some improvement, but we're not going to leave him this way. We did an angioplasty 6 months ago and it shut down, so clearly he needs a stent. And so we went ahead and placed everolimus-eluting synergy stent, 2.25 millimeter by 16, just proximal to the distal branch of the right there. You can see the kind of vessels we're dealing with in a 6-year-old. Even the healthiest part of the right coronary is 1.3 millimeters. I mean, we're talking about tiny, tiny vessels to deal with. And a surveillance look at that left main and proximal circ, which looked very good. A little bit of intimal proliferation in the proximal circ, but really not bad. And after this stenting, the warfarin was discontinued. As Jane stated, once you don't have aneurysms, there's really not much role for continuing the warfarin. And he was maintained on aspirin and clopidogrel. At 7 years of age, he underwent another surveillance angiogram, and that showed that the left main was widely patent, and the circ. But look at that right. So the stent, it looks great distally, but look at now the intervening segment between where there was the first and the second aneurysm. There's now a diffuse area of narrowing there. And the FFR was 0.58, so highly significant. And we use FFR when there are these sort of intermediate lesions that of unclear significance. We do physiologic testing, and this documents that clearly it is an area of highly significant stenosis. And this is after placement of stents here, proximal stenting here with a 2.5 by 16 and 2.5 by 12 synergy. This should be, say proximal, not distal, pardon me. So he continues on aspirin clopidogrel, and he's going to undergo regular stress MRI and cath as needed. Here's another case. This is now a little bit a departure from Kawasaki, just to keep everyone interested this morning. 1-year-old, 8.3 kilo Hispanic girl presented in cardiogenic shock with severe hypertension. The echo showed severely depressed LV function, and she actually developed a right frontal stroke that was thought to be possibly cardioembolic in nature. So she was transferred to us, and I took her to the cath lab. If you're wondering why this organ has no ejection fraction, it's because it's the kidney. This is the left kidney showing a very, very tight, nearly occluded left renal artery. And we've seen several children present like this with severe ventricular dysfunction because of very early development of severe renal stenosis. We've had even renal artery atresias that we've had to recanalize in babies as young as 2 or 3 months of age. And this is what it looks like after angioplasty in 2 distal branches and in the proximal branch as well, with up to a 2.5 millimeter balloon. She underwent angioplasty of the right upper pole, but to be brief, I'll skip everything else we did. She was found to have diffuse superior and inferior mesenteric artery stenoses throughout the distal bed, and later was diagnosed with moyamoya disease as the cause of her stroke, not a cardioembolic phenomenon after all. This is what her superior mesenteric artery angiogram looks like. She has a replaced hepatic artery originating from the SMA, and you can see these distal stenoses throughout the vascular bed here, extremely abnormal. She had a dural inversion procedure for her moyamoya disease and returned for additional renal angioplasty at 3.5 years of age, and then a surveillance cath at 4.5 years of age. And this is what her renal artery looked like. You know, surprisingly good response given the severity of disease and its early presentation. During the renal angiography, ST segment depression was seen by our very astute anesthesiologist, Dr. Rashedat, who saved her life by being very attentive to details and said, hey, every time you inject down there, she's developing ST segment depression, what's going on? So I said, let's go do a coronary angiogram and see what this could be about. And lo and behold, she has an almost completely occluded long segment LAD lesion. The proximal right is involved as well. And I'll play the left coronary. What you see here on the left is basically that the circ is very abnormal as well. The distal circ is gone and replaced by collaterals. The LAD has a long segment area of narrowing right across here that covers half the LAD. And what do you notice? You fill the right. And when you fill the right on a left coronary angiogram, that's never a good sign. That's a sign that there's proximal right disease. So she has 3-vessel disease. So at this stage, we decided that we should not intervene at that procedure and instead make sure that she does have a true perfusion defect, and she did by MRI. So she was taken back to the angioplasty 3 months later at 5 years of age, weighing 16 kilos. And this is what it looked like on the right. And this is what it looks like. I'm showing this only to highlight the difficulty we face in small children. This is a guide catheter. Guides are very large bore catheters that we use to deliver balloons and stents. Unlike diagnostic catheters, they have much larger lumens for this purpose. But these come in pre-shaped curves that are very convenient for adult coronary use because of the variety of sizes of aortic roots in adults. But there are no guides made for children who weigh 16 kilos. And so you see on the left, you can't even hardly see the coronary artery. And on the right, you've deeply intubated the coronary, and this is all within a millimeter or 2 of advancement of the catheter. And this is what it looks like on the left. You can see again that long segment LAD narrowing. This is a technique that we've actually developed here, we think. We've not seen this described earlier in other places except in the neuroradiology field, where we're actually getting into the coronary arteries using a microcatheter and leading with a microcatheter rather than a wire, because wires are actually quite traumatic and difficult to make those tight turns, and these microcatheters are used for neuro interventions. They're very soft, they're almost liquid. They advance down the vessel on their own, so we can actually guide it down there. And this is what it looks like when we inject contrast down to the microcatheter, trying to get through that lesion and finally cross it and take a picture there before we balloon it. And when we're all done, this is what it looks like. And we're pretty pleased with that result. But we brought her back 5 months later, and we were very pleased that it actually stayed open. So we're going to be watching her very, very closely, but it shows the fact that this can be done. We had ECMO backup because of 3-vessel disease and trying to deal with a long segment LAD, but she actually tolerated everything beautifully and is doing very well. This is what her right looks like. I'll close with this case of a fetal hypoplastic left heart syndrome with intact atrial septum. We placed an atrial septal stent at 24 weeks gestation in a fetal intervention. And the patient was born, did very well, had initially vigorous and exactly what we would want from this fetal intervention. And then the patient had an orbit operation at 5 days of age. At 8 days of age, weighing 3 kilograms, he became abruptly hypotensive with EKG changes on the monitor. The echo showed severe ventricular dysfunction, and the patient was placed on VA ECMO. We took him to the cath lab. Actually, initially was taken by my excellent colleague, Dr. Qureshi, at the back. He took the patient to the cath lab on ECMO, and this is what it looked like. you can see there's complete occlusion of the left coronary artery. And you can see that the patient has a little bit of flow into the tiny hypoplastic left ventricle through a barely patent aortic valve here. And what he did is just using wires, and this is again very challenging. Not only is this child small, look at the size of this ascending aorta, trying to get a catheter to sit right and to point correctly and provide the support we need is certainly challenging. But the patient being on ECMO and with a lot of persistence on his part, he got through and wired the coronaries and reamed out the coronaries and got flow down the circ, which you see down here. This is the very small left AV groove here. This is a small circ. And you can see that the LAD has a little bit of flow, but really not a lot. And you see collaterals distally in the left side of the heart here that are perfused through collaterals from the right. So there's clearly a persistent occlusion going on, but the patient was much better. So we decided we're going to take him back to the ICU and then leave him on heparin and then bring him back the next day and make sure this has stayed open. So I took him back the next day to reassess the coronaries, and the circ was completely open, and this is what it looked like in the left after we performed. Here's a wire going down the left main, and here's after balloon angioplasty. We were able to place the smallest available balloon on the market, which is a 1.2 millimeter balloon, all the way down this left anterior descending coronary, and what I think I ended up doing there is actually opening up what was a congenital stenosis there. He had LV to coronary fistulae, as we see in patients with hypoplastic left heart syndrome sometimes, and there was a dense fibrotic stenosis that opened up with the balloon. This again was very, very challenging. We had to use a long 4 French sheath as a guide catheter all the way into the aortic root, and the patient actually amazingly recovered ventricular function and was able to undergo a second operation for tricuspid valve repair and had a very good quality repair of the tricuspid valve and came off ECMO and had stable ventricular function, but unfortunately died of overwhelming infection several weeks later. So again, not a good outcome for the patient, but an indication that coronary interventions can be feasible even in very small babies. But clearly this case was challenged by the availability of catheters, et cetera, in children this size. So let's spend a few minutes just talking about the rationale for percutaneous coronary interventions in children. Should we be considering this? Should we not? Clearly we're outside of the realm of established guidelines. So what are we to do with young children with coronary disease? Is it reasonable to do PCI? Well, I'll provide you sort of an opinion. Clearly we don't have data to back this up, but first, I think it's fair to state that we don't burn bridges by doing a transcatheter intervention on a coronary artery. So when considering a bypass graft versus a stent or an angioplasty of a coronary artery, I think it's fair to state the following, that when we're performing a stent or an angioplasty, we're doing that at the site of the stenosis. And that's not the site where the surgeon is going to graft the healthy mammary artery onto a diseased artery. They're going to graft onto the healthy part of the artery beyond the stenosis. So as long as we're careful and we don't extend stents way distal into and consume a portion of the healthy vessel, we should be able to place a focal stent in the region of stenosis and not burn any bridge for future bypass grafting into that coronary. I think it's difficult to claim that CABG is considered definitive therapy. It is the best, most durable therapy that's available, and that's well shown in adults. But in very young children, the technical challenges of performing a bypass graft in an infant or a toddler certainly have to be weighed against the fact that we also don't have 80, 90-year data on our coronary artery bypass grafting. So I think we should really reserve that ACE for when it's absolutely needed. And I think that should be reserved as a last option. Let the child grow, have a more successful and more durable anastomosis later on, but palliate the child early on in life with catheter-based procedures if possible. We accept that PCI itself is also not definitive. We have no data to suggest that it is, but at minimum it delays CABG by several years so that the child can grow and again have a more successful anastomosis. God only gave us 2 internal mammary arteries, and we really should try to save those 2 ACEs for when they're absolutely needed, and we know that saphenous vein grafts have poor durability and it's a poor backup option. What are the drawbacks of pediatric PCI? Well, as I mentioned, guide catheters are not available in small curves for optimal support in PCI, and that makes the procedure very, very challenging in small children. Small diameter stents, such as under 2.5 millimeter diameters, have poorer patency rates in adults. Now, that's something that remains to be seen in children. We know that adults, especially diabetics, who get very, very small stents placed in their coronary arteries, the patency rates are poorer, but it's not entirely clear whether that's purely related to their underlying diabetes, for example, or it's directly related to the absolute diameter of the stent. In children, we have no way to know. There are no data to guide us on that decision. Coronary stents, remember, need to be redilated to keep up with the child's somatic growth. So it's not a solitary intervention that we're going to go in and then leave the stent alone. First, those children will need not only frequent surveillance catheterizations to monitor the patency of the stent that we place, but also to monitor the progression of disease elsewhere. As you see, we may be thinking we're going to go in and stent one vessel, but when we go check the other coronary, it may have developed a new occlusion that we weren't expecting. So we do have to keep that in mind, and when we place a stent in a small child, anywhere in the body for that matter, we always tell the family this means we're cementing a relationship of having to come back and redilating that stent to expand it as the child grows to keep up with the somatic growth. So I'd like to acknowledge my colleagues Jose Diaz and Mahbub Alam, who are the adult interventional cardiologists that we've most closely worked with. As Athar mentioned yesterday, we've learned a tremendous amount from them. We're grateful to them for teaching us. They can even teach these old dogs some new tricks, which is nice to know. And together we're I think, trying to make a difference in these children with coronary lesions. So thank you very much for your attention.